Hello, and welcome to Ethics on Call, the podcast of the Center for Theology and Ethics in Catholic Health. I'm Dan Daly.
Hello, I'm Tom Bushlack.
And today we'll take up the recently promulgated seventh edition of the Ethical and Religious Directives for Catholic Healthcare Services. So many of our listeners will be familiar with this document insofar as that it's the role that it plays in Catholic health and the fact that it has been recently updated as of November of 2025.
Mhm.
And so, Tom, do you want to bring us through the plan for the episode as we discuss these new developments in the document?
Yeah, absolutely. Big moment for Catholic healthcare in the United States. And I'll just note that we will probably have some future episodes continuing this discussion. But for today, we're going to start by talking about the context for these ERD revisions, a little bit about the comments that Bishop James Massa gave at the plenary when these were voted upon. Then we're going to have a conversation with Dr. Nathaniel Blanton Hibner, who's the Senior Director of Ethics at the Catholic Health Association. He's going to give an overview of the process over about 4 years by which these were revised and updated and given input. Then we're going to talk about what you and I see as kind of the four under the radar developments, maybe not quite as um, big headline or
Right.
substantive developments, but still significant. And then we're going to talk about what we see as the big four developments. So, new ERDs on care of transgender persons and persons experiencing gender dysphoria, some new language on abortion, a new ERD, a new directive on VSED, which is a short acronym for voluntary stopping of eating and drinking, a new practice, and then new comments on palliative care that have made their way into the directives. So that's kind of our overview for today.
Yeah, thanks, Tom. Now, I know that you had watched the November USCCB meeting,
Mhm.
and you were watching for Bishop Massa's comments as the session on the ERDs began. And would you be able to provide some of that context, I should say, that he provided as that session began? I think it'll be helpful to know what the context is as we then look to what the document actually has become.
Yeah, absolutely. And like most Americans, I was glued to YouTube watching the plenary session of the USCCB. Actually, like me and a few other people that work at CHA and in ethics and Catholic healthcare. And just note that Dan, you were in Rome at the AI conference during that. So Nate is actually going to unpack this a little bit more, but watching the introduction was very informative to see how Bishop Massa and that Committee on Doctrine proposed these new changes and why they were doing them. So he really starts by noting that the sixth edition, so the new one is the seventh, really provided no guidance on care for transgender persons or persons experiencing gender dysphoria. So that was really the kind of primary reason for wanting to revise and update the ERDs. You'll hear more about this throughout. There was a doctrinal note on the moral limits to technological manipulation of the human body, published by the USCCB in 2023. That kind of started the process. Then Dignitas Infinita was published by the DDF, the Dicastery for Doctrine of the Faith. Make sure I say that right. In 2024, so there were some new teachings in there to update. So Bishop Massa notes that after that doctrinal note at the plenary assembly of bishops in June of 2023, the bishops at that point voted to begin the process of revising the ERDs. So it's about a 4 year process. Um, so the major update and the original impetus came in part three of the ERDs. And then once that process was opened, the bishops, had an opportunity there's always new developments in the practice of healthcare. There's also developments of ethical thinking and doctrine that occur. So there were some revisions made as well to parts one, four, and five, and we'll talk about those in what follows. And then he noted that all the bishops were able to see what revisions had been made over the last 4 years in advance of that plenary assembly in November 2025. And they were also provided the opportunity to make proposals for ongoing amendments to that document that were then voted on. And just as a matter of procedure, in order for the new ERDs to be officially promulgated, that required approval by 2/3 of the membership, which it received well over that approval. So that's kind of what I took from Bishop Massa's opening comments, which were really helpful. And we're going to turn now to that interview with Nate, Dr. Nathaniel Blanton Hibner, who again is the Senior Director of Ethics at CHA, who's going to tell us a little bit more about the process and who was involved in that as the ERDs were revised and updated.
So we are here at Once Films in St. Louis, and we have invited in Dr. Nathaniel Blanton Hibner, the senior ethicist at the Catholic Health Association. And Nate, you're here today to talk about the ERDs and the process. And thanks for being here.
Well, thank you, both of you, for having me. I'm glad to be able to have the opportunity to discuss a little bit about the process and how CHA was involved and the way the membership really came together in order to achieve, the outcome that we have.
Great, thank you. So I guess the first question is, what was your role in this process? I mean, you played a major role in organizing folks at CHA, and that's, in terms of the members. Can you talk a little bit about your role in the revision process?
Certainly. So usually how the USCCB develops texts is a committee is assigned, or they're the ones that lead it. And then the staff members of that committee are the ones that kind of put together drafts, receive comments, talk to the bishops themselves about what works and what won't work. And in doing that, they reach out to experts beyond the conference in order to get feedback and suggested changes. And so CHA was one of those. And therefore, at CHA, I took kind of the primary point, the lead, as you described it, in order to formulate our review and our suggested comments. And that would involve receiving a draft, looking at what kind of changes we'll put in there, and then based off of those, figure out what expertise we might need from the membership or from other Catholic allies like higher education, and have them help me review the document, provide the feedback, consolidate all those kind of comments and reviews into a readily understandable format that was then shared back with the staff member of the doctorate committee, who then, in their own way, reviewed, processed, talked to bishops, and would then come out with a new draft, and we do this all again.
Do you recall how many times that occurred in this current review of the 7th edition?
So we saw 5 drafts over a 2-year period. And usually a draft would come out after the doctorate committee already had a meeting. So we, in some way, were able to expect a little bit about when it was going to happen. But then when we receive it, and I must say, in every sincere way, how grateful I am for the membership to be able to drop, on a drop of a hat, be able to come together. Because sometimes we were only given 6 weeks in order to respond. And I would gather comments from 24 different experts. I often flew them several times, flew them to come together, and they were all willing to do so with no questions asked. So we saw 5 over 2 years is how many times we had to review, collect, and comment for the review.
And so, yeah, can you speak a little bit more about that, the overall process that the USCCB did? You've already gotten at it a little bit, but when did they start doing this? When did they invite you in to put together these groups of members? Tom and I were part of those groups with you and so many others. That were really incredible conversations. But can you just narrate the process that the USCCB Doctrine Committee did to get the document from where it was in the 6th edition all the way to, passing it in November at the meeting?
So I get asked a lot, what prompts a revision? And when you ask the doctorate committee and the staff, it's one of 2 things tends to prompt it. It's either there has been an updated or a new theological teaching that touches upon healthcare or bioethics or somewhere in the medical field that they feel needs to get into the document and into the hands of practitioners. Or there has been a new technology, or there's a new question in the medical and science realm that they feel that they need to respond to in order to, again, get it to the hands of those who are taking care of patients. So those are kind of the two areas, the two reasons why they might update it. There's no timeline. Some people ask, oh, do they update it every 3 years or 5 years? No, it's always one of these two things. And so for this particular one, it was the question about gender. And the doctor committee wrote a moral note back in the spring of 2023. That was kind of their beginning attempt to answer some questions around what the church says regarding gender affirming care or gender transitioning and gender dysphoria. But they wanted that document and kind of that teaching codified in the directives, moved over to this document that is, well, just more read than a moral note from a committee from the conference, for example. And so we knew after the moral note came out that discussions were already happening, that at their June 23 meeting, that the doctrine committee was going to ask the full body of bishops. The full body has to vote to open the revision process. So we knew that was going to happen. So we waited, June happened, the vote happened. They approved, the full body approved almost unanimously that they should start revisions. Then we didn't see the first draft until that fall. I think it was October. In fact, I was on a beach in Hawaii with my wife when that document came out. And I'm grateful that she was willing to deal with me rapidly sending emails while we were on vacation. And then we started that whole process of reviewing it, getting expert comments, bringing people together, and sending off the revised suggestions. From there, we a little bit are unknown about kind of how the doctrine committee chose which comments or revisions to accept and which ones not to. Over the 2 years, I and others at CHA were able to have conversations with the staff to try to get a better understanding of that rationale. You know, what were the goals they were trying to achieve because of a different revision that they chose. And we wanted to convey to them that if they let us know what they're trying to achieve, that we can help them obtain that goal in a practical and real world way, that we understand the audience in such a way that we can help them write it so that it's understandable, it has some clarity, and therefore it better achieves the goal that they have expressed to us. So we were able to do that a handful of times. But otherwise, we did this back and forth by forms and emails and occasional text message. I mean, this kind of stuff, a very digital kind of way of dialogue.
And in between, so once everyone gathered, saw the draft, you collated those comments, sent them off. Then what was in between each of the 5 revisions? What was the process like there?
So some of it was already preparing, because you might see the same revision kind of beginning to firm up as the drafting process. So you might see a particular new directive or a way that they have decided to edit or phrase something. And if we saw it in the first and the second and the third, we're like, okay, well, that must be something that's going to make it all the way to the end. And so we could then begin to prepare the resources that will come out after the final vote to help explain to the membership what those changes are and how they might impact the way that the membership delivers care. So there was a lot of that kind of preemptive planning in between each draft that we were permitted to see.
And how do you think the doctrine committee received the comments that came from you and the CHA members who helped you to create those comments on the drafts?
So how I could describe, since we did not have any direct dialogue with the bishops of the committee during this time, everything was filtered to the staff. What I can ascertain by looking at the different revisions is the CHA comments and suggestions must have been fairly well received because we saw a lot of them be accepted. And we saw a lot of them either accepted fully because they did ask us. They were very they wanted specific. They did not say, "Oh, give me a broad suggestion about how this should be changed." They very much said, "Give me the sentence that you wanted included," and so we had to do that. Not all of it was obviously accepted. Not all of our suggestions were obviously accepted, but we kept seeing progress. We kept seeing areas where we had positive influence between the drafts. So I like to think that they saw our real world knowledge and expertise, the breadth of the number of kind of experts we were bringing into this conversation. We weren't siloed to one very specific either viewpoint or knowledge. We had, again, a plethora of individuals. They saw that as helpful and they took that in a very positive light.
Yeah. What are your takeaways? Now that the document is public, it was passed in November. What are your takeaways as you look at the final product?
So a couple things I would have to say. One is the directives as a document, as its kind of entity, is an attempt to distill all of this broad church teaching on the subjects that touch upon healthcare into digestible paragraphs so that people on the ground by the bedside have kind of an immediate direction they should be going when faced with certain moral dilemmas. So what this document has done in this version is taken some of those more recent theological texts since 2018 when version 6 was approved and brought it into this document so that people have better access to it. And so examples that I can give of that. Dignitas Infinita from the CDF in 2024. That document is now cited and even basically quoted in the document. Samaritanus Bonus from 2021. That about the end of life and the chronically and terminally ill, that was brought into this document. So those teachings already existed. Those were already formal teachings of the church. So we were already living them out. This is now trying to get a different format that better helps those who are not trained moral theologians like us have a starting point on where to go during moral dilemmas. The second thing I think I like to take away from is they voted, it was approved. That's not the end of the conversation. That there is still interpretation that needs to happen in the coming months. That there's still some ambiguity in certain phrasing in some of the directives that we need to really flesh out in conversation with bishops, not just those of the doctrine committee. It's now member to bishop conversations about how they want to live out this document going forward. And that's going to take a period of months. And I believe that the doctrine committee and bishops understand that it's going to take some time for us to interpret, understand, and then actually apply what the changes have been done in this version. So those are the two things, the codification and the continued need for dialogue going forward.
Well, great. Well, thank you for your time, Nate. It's been a pleasure to listen to you talk about the ERDs and the process and your insights here.
Thank you very much. Thank you very much.
Yeah.
Thank you for, again, you both helped during these last 2 years, and grateful to you and to, again, all the members who participated in this process.
It was a really great process. It was an honor to be a part of it and fun to see how the sausage is made, as to say.
Yeah, that's right. That's right. So well done.
Thanks.
Thank you again.
So thanks again to Nate for that interview. Tom and I, we really enjoyed talking to Nate about it. It was great to be with him in St. Louis, where we recorded that interview. But now I'd like to turn to these 4, as you noted, Tom, these 4 under the radar developments that we noticed as we looked at the document. And what are those? Which one stands out for you?
Yeah, I think the first one that jumped out when we were talking about this is a renewed attention that gets mentioned several times throughout the document to care for women, and particular emphasis on areas in which women are especially vulnerable at different periods in their lives. I mean, we could say in all of society, but particularly in the healthcare system. So there were three. And in some ways, this could be a bigger one, but it's the references to it are you'd almost kind of miss them if you didn't know exactly how it was phrased in the previous edition. So at the introduction to part three, there is a oh wait, that's incorrect. Not the introduction to part three, ERD number three. There is actually a list of vulnerable classes of persons that deserve special care and attention when receiving health care. And so the this new edition adds the language of pregnant women to that list of vulnerable persons. So that's pretty significant. In the intro to part four, and part four is the part that deals with care at the beginning of life, there was a reference to special concern for addressing causes of infant mortality, and this new version adds infant and maternal mortality. And of course, we know that maternal mortality again among other classes of women who are minorities or excluded in other ways also have higher mortality rates. So it opens the door to those kind of social determinants of health kind of analysis. And then ERD number 44 adds a note about providing especially care and accompaniment during and after miscarriage. So there's just a growing awareness of the ways in which women experience particular forms of vulnerability and therefore need special attention, care, and protection when we interact with them in the healthcare system.
Yeah, no, it reminds me of, there's, I think this is what you just said are connecting to two other themes that we're seeing developing that we'll say more about as the podcast goes forward. One is a continuing and deepening awareness of those who are vulnerable in the healthcare setting, the widening the aperture to include more people in that. So I think that's a really important development.
Hmm.
And also an increasing development in the area of accompaniment, this kind of relational aspect of healthcare. They're amplifying that too, and we see it certainly in the work that they do on an inclusion of women in the increasing inclusion of women in these directives. The one that I think was interesting, it's a small one, Tom, but I think it's still interesting, is if you look at the introduction to part three, which is on the professional provider relationship. They there and only there in the document did they change the language from provider, right, talking about healthcare professionals as providers, doctors, nurses, allied health care professionals, right? We often refer to them as providers. But in the intro to part three, they changed the language to professionals.
Hmm.
And that goes along with what the title is of part three. Again, as I noted, it's the professional patient relationship. But it also made me think. I had recently been reading a book of an edited volume on Edmund Pellegrino's writings, and came across a piece in which Pellegrino said, this is in the late 90s, and he was seeing the change in language from talking about physicians and nurses as professionals to having them discussed as providers. And what he argued was that language distorts the nature of healing and helping, which is what it means to be a physician, nurse, allied healthcare professional. And that language functions. I mean, the argument that he makes is it functions. So if I start to see myself as a provider, well, then I'm providing a service as opposed to I'm caring for the patient. So, I don't want to make too much out of the developments in the language that they use, but I find it interesting. And there is a theoretical argument here, a theological philosophical argument that says, we should be thinking about these people as professionals, as physicians, nurses, not as providers. So again, they retain the language in the rest of the document, but that one change I think is interesting, and maybe others in the listening audience will find it interesting as well.
Yeah, and it really jumps out in that intro to part three because we have a text that has like in red all the changes, and it's a lot there. And I hadn't really thought about it even until hearing you reflect on it a little bit more, how provider can really fall into that language of economic transaction versus healing encounter, you know? So we don't necessarily know who proposed that or why it's in there, if it was a direct reference to the Pellegrino article, but it certainly seemed like it was intentional and signals something which we find, I guess, congruent with our understanding of the healing encounter that happens in
Right.
healthcare. Yeah. Um, Another one that we noted was in part five, which deals with care at the end of life for persons who are at end of life or in the dying process. The language in there talks about the patient and the patient's um, preferences and decisions throughout. But there's an added language there that we see where it now says patient and his or her surrogate. So there's a kind of just a growing recognition that, which is congruent with my experience of having done ethics consults, is that oftentimes you are dealing with an identified surrogate. And then depending on your state laws, sometimes surrogates aren't listed in terms of priority. So sometimes we were dealing with, entire groups of family members all making surrogate decision making. But there's a recognition that the patient and their surrogate is very important for considering what is the wishes and intentions of the patient at the end of their life.
Yeah, and the language was always there, but they really, I think what they tried to do was make it more consistent. So in
Hmm.
that part five, you see it's patient and surrogate. And again, I think you're right, Tom. I think it's a recognition of the important role that surrogates play. To your point, yeah, and, most ethics consults for patients at the end of life involve a surrogate to some degree, if not
Hmm.
the surrogate as the decision maker for the patient. So yeah, I think it's that it's more in consistency. They're providing this language more consistently, which I think is really interesting. And the last one that we identified was, and I just briefly mentioned it, there really is an increasing emphasis on the non-medical side of providing care. There's a real emphasis on the pastoral and relational aspects of healing, which I think is really interesting. It's there's an increasing focus on the holistic care that's provided in Catholic healthcare facilities. And I see the imprints of, or the influence of, I should say, Samaritanus Bonus
Hmm.
is really reflected throughout the document, but I would say especially in part five, where, if you go back and read Samaritanus Bonus, the word accompany or accompaniment is found throughout the document. And we see the word accompaniment for the first time in the ERDs in the seventh edition. So I think that's really interesting that they're earlier you said they update these documents because there are medical technologies that have developed, but also there's theological and moral developments that happen in the tradition. And this is certainly a theological moral development that they integrate in a really interesting and important way uh, in this edition.
Yeah, and I'll just add for those who might not be familiar with what Samaritanus Bonus is, I'm sure some listeners are and some might not be. That's a document put out by the Dicastery for the Doctrine of the Faith in 2020. And the kind of English subtitle is On the Care of Persons in the Critical and Terminal Phases of Life. So there are both direct citations in part five from that document, but also just like you said, you can kind of feel the tone of that being integrated in there. Um, and I'm kind of just reflecting on, the episode that we recorded on Pope Francis's legacy and influence. We saw that move towards really meeting persons in their concrete reality and where they are. And again, I think that's just I'm not that isn't directly cited in the document, but it's an interesting sort of parallel movement that we're seeing in theological discourse that we see now being integrated into the ERDs as well. Anything else on those four under the radar, Dan, before we move on?
I think that's it. I mean, I think, people will pick those up as they read, but we just found them interesting enough to mention to the listening audience, because they're not, as we get into the big four developments, they're not part of the big four explicitly.
Yeah, exactly. Yep. Okay, so we are going to jump in now to the big four, and just I'm going to run down the four, and then we'll jump in. Again, it's the care of transgender persons, the new language on abortion, the VSED, voluntary stopping of eating and drinking, and then the palliative care references. So we're going to start with, again, as we've already noted, the main impetus that was anticipated and known for this new edition of the ERDs was to have some directives around care of transgender persons and or persons experiencing gender dysphoria. The bulk of those changes can be found in directives 27 through 30, which is part of part three, which, as you mentioned, Dan, is dealing with the patient and healthcare professional relationship. I had to pause to make sure I used the healthcare professional and not provider. And we're going to focus especially on 28 and 29. And as we noted, they almost kind of have to be read together as like a pair, where 28 really outlines some of the more doctrinal or ethical developments in the tradition, and 29 really focuses on the pastoral, person-centered aspect of dealing with this phenomenon that we're seeing increasingly. So, Dan, I'm going to throw it to you for kind of walking us through what's in 28, and then we'll just go from there.
Yeah, thanks, Tom. I think, the first thing is that these were, as you noted, very much expected. This is the purpose of opening up the document to revisions. And also the content was very much expected, given that we had the USCCB's Doctrine Committee in 2023 write a doctrinal note on the care of transgender persons. And then, as you noted, Dignitas Infinita, it takes it up as well in paragraph 60. So we've got two documents in the last couple of years that look at this, because before that, there had really never been an explicit magisterial teaching on the issue of care for transgender patients. So, but we get the doctrinal note in 2023, we get Dignitas Infinita in 2024. So we've got these two documents back to back, and then in 2025, the USCCB uses those documents as guidance as they develop these two directives.
Mm-hmm.
As you noted, 28 is the doctrinal note. And essentially, I'm sure many of our listeners have read it. 28 basically, the takeaway from 28 is that Catholic healthcare services cannot aim or intend to alter the fundamental order of the human body. That's a term, the fundamental order of the human body is a term that they get from the doctrinal note. So the Catholic healthcare can't aim to alter that fundamental order, to transform the body into the opposite sex. And there they specifically cite the prescribing of hormones, providing surgery, or genetic engineering for those purposes, right? What's interesting is they draw on, again, as I noted in the footnotes to that directive 28, they draw on Dignitas Infinita, paragraph 60. And I'll read what that paragraph says. So Dignitas Infinita, which you noted is a document of the Dicastery for the Doctrine of the Faith,
Mm-hmm.
writes, and I quote, "Any sex change intervention, as a rule, risks threatening the unique dignity the person has received from the moment of conception." End quote. The theology here, both in Dignitas and in the ERDs, but also the doctrinal note, is about accepting the body as it is created as a gift, right? So that's the underlying theology. The body, the person is a gift, and the idea is the person accepts that as a gift, including one's sex. Um, you know, so the doctrine there, I think, is pretty clear in terms of what the bishops are saying that Catholic healthcare services shouldn't do, and the reason they shouldn't do it. Um, but I think there are questions that we have to ask and answer. I think this requires Catholic healthcare to deliberate about which interventions aim to alter the fundamental order of the human body or constitute what Dignitas Infinita calls sex change intervention, right? What are those interventions? We do a number of surgeries to the body that are changing parts of the body. Where are the where is the kind of the guidance on specifically what can and cannot be done? And I think that's, as we'll note, I think that's something that's going to emerge over time. Um, I think there's further conversation that needs to be had on what it means to say that there's a fundamental order of the human body. Um, as I can tell, that's the first time that that's appeared in Catholic moral theology, that there is this fundamental order of the human body. And so I think more study is needed on that concept.
Yeah, I just wanted to clarify when you said first time, you mean in the doctrinal note in 2023, correct?
Yeah,
That's
the first
yeah.
time, yeah, the
Yeah.
doctrinal note, and so to begin to understand what that is, I
Hmm.
think is going to be an important. There's important work that needs to be done by theologians, by ethicists on that.
Yeah.
And then I think there are specific questions. There have been these questions that have been in the air for a while. What about if a patient comes into one of our facilities who is on hormone therapy?
Hmm.
Um, can we provide those hormones for that patient, even if we didn't originally prescribe them? Or a patient comes in post-operatively, a transgender patient comes in post-operatively needing some kind of a surgical intervention, right? So there are further questions I think that need to be asked and answered um, along these lines that I think that will emerge over time. This is such a new uh, field of medicine, and here we're getting really strong guidance from the bishops. And then the next question is, how do we use that in the care for patients?
Yeah, and I think on that point, it's important to note, I can't think of specific examples that I've seen in the media, but there's nothing in here that says that we cannot provide that kind of care and treatment for people who maybe have already undergone hormonal treatment or need care, that in order to receive the best care, need to have the fact that their process in that transitioning process has already begun elsewhere. And so that's something that is really being worked out, in the interpretation of this. But there's nothing in here that says, if a transgender person shows up at a Catholic hospital or clinic, that we have to turn them away, right? I think that's really important, and it kind of leads into 29, which deals with, we have the doctrinal ethical dimension of 28, but we have real people that we're dealing with, and 29 especially deals with that. So I know you have some more to reflect on that, and I think I do too, but I'll hand it back to you.
Yeah. What I think is so interesting about 29 is here the bishops really do focus on caring for the needs of those who suffer with gender dysphoria. And they name those people as a special group of people who are especially vulnerable. The bishops here really do recognize the suffering of people with gender dysphoria, transgender patients. And they say that we should do everything appropriate to relieve their suffering. So there is a real focus on the suffering of these people, which I think is important to note. These people are not to be demonize. They are not to, they're not, they are people who fully reflect the image of God, and they ought to be cared for in Catholic facilities with that notion in mind. And it also reminds me of Cardinal Fernandez gave a speech in February of 2025, and he's the head of the DDF, right? Cardinal Fernandez. And there he noted, and I'll quote him, when the document, and he's the document he's referring to is Dignitas Infinita, paragraph 60. So when the document uses the word normally, it does not exclude the fact that there may be cases outside the norm, such as severe dysphoria, which can lead to intolerable existence or even suicide. These exceptional conditions must be considered with great care, end quote. So Dignitas Infinita says, as a rule, I read it earlier.
In the English translation.
The English translation is, in paragraph 60, is as a rule. The Italian is de norma. So in the original Italian, it's translated as a rule. If you talk to an Italian speaker, they would say that also can be translated as normally. So here, what Fernandez is doing is right in line with what the USCCB does in paragraph 29, that these are people who should be treated with great care. These documents are in agreement. So again, we're getting Fernandez's interpretation of Dignitas Infinita, which, by the way, his office promulgated. So he knows kind of what the meaning is of this document. And I think, it really leads us as Catholics to think about how do we provide that great care for these people who are in, as he notes, exceptional conditions, right? Who are suicidal, who have a quote unquote intolerable existence. I think this requires us to do a lot of thinking about what that care is, so that we can serve them in their suffering.
Yeah, Dan, really appreciate those comments, kind of putting it in context of the broader theological discussion. And even to put this in the context of, reading both 28 and 29 in the broader context of the mental health challenges faced by people who are struggling with gender dysphoria. I looked at some of the research out there that in general, persons who identify as LGBTQ plus are already 3 times as likely as the rest of the population to attempt suicide. So not just to think about it, but to attempt. Now, if you drill down within that group of folks who identify as LGBTQ plus, and you focus on trans and non-binary persons, so persons who identify as trans or non-binary, they are then twice as likely as the rest of that group to attempt suicide. Again, not just thinking about it, but attempt, and to experience major depressive symptoms. So I think that's just part of that pastoral and relational context that we're talking about, and providing great care when we step into how these are going to be lived out going forward and interpreted. And then, we kind of mentioned that 27 through 30 kind of form a bit of a block here. So as we were talking about this, Dan, I know both ERD number 30 and number 33 had some language that we thought was relevant here. And in particular, ERD number 30 doesn't use the language of the principle of totality, which some listeners very familiar with Catholic moral theology will know comes from Pius XII. But it does talk about considering the whole person. So they don't use that language of principle of totality, which is out there in the discourse, but they do cite Pius XII talking about some of these things. So again, it's looking at the whole person as a unity of body and soul, and providing care that cares for the whole person and the whole body. And then number 33, also, it starts out, the well-being of the whole person must be taken into account in deciding about any therapeutic intervention. So again, I think just noting that, we talk about this as kind of like intertextual interpretation. as we look at this whole section, that we need to kind of just keep considering how do we interpret these in light of each other as we move forward. And then, what did you want to comment on the 30 or 33 at all?
Yeah, no, I think it's a good point. I mean, what the bishops are asking us to do here is serve the well-being of the person, and very much following. I mean, this is John Paul's great development, his personalist approach to moral theology, and centering the person and the well-being of the whole person. I mean, that was incredibly important in the development of church teaching. We see the theology of the body that he develops in the early 80s that is right in line with this personalist approach. And you see that reflected here.
Hmm.
And it's, he's not the one who invents it. He codifies it, right? As you noted, Pius is doing this work as well. And we can go all the way back to, we can talk about Aquinas and Augustine doing similar kind of work, the great theologians of the tradition. But yeah, we've got patients who are vulnerable in many ways, and how do we care for them as whole persons? And I
Hmm.
think that is the unique charge of Catholic healthcare, as that continuation of Jesus' healing ministry. Jesus cared for the whole person, and Tom, you're right to say 30 and 33. I see those as really reflecting that healing ministry of Jesus Christ continued in Catholic healthcare.
Yeah, that's really well said. And then, kind of a final thought, maybe on this section on transgender care, and this is echoing what we've also heard in discussion with Nate, who we interviewed earlier, and this has to do with the way in which these ERDs function and when they're promulgated, right? It is up to each local ordinary, archbishop or bishop, to interpret and apply these documents. And that's going to be, as we've noted, an ongoing process. So, a lot of Catholic healthcare ministries and providers and professionals, even before this came out, were already having discussions with their local ordinary about, how do we do this? How do we best care for persons coming to our door who are experiencing gender dysphoria? So, just to kind of reiterate, if you've already had that conversation, probably a great time to have it again, especially if you're in a role where you're in dialogue with your local ordinary. And if you haven't and you're working in this field, I think this is, a real important time to have that discussion with your local ordinary about what exactly they expect in terms of how this is interpreted, practiced, and applied within the authority that they have within their own diocese or archdiocese. So I think that's a real practical point to take away as well.
It is. Yeah. Yeah. I think it's a great bit of advice from Nate
Yeah.
that you're handing on. As we look down the line here, the next issue that we saw as one of the big four is in number 45. We have a clarified definition of abortion. And so while they open up the document, they said, look, we want to get more clarity on this, the definition of abortion, and they bring it in line, as the footnote suggests, with Evangelium Vitae 58, where they talk about this kind of deliberate and direct killing that's chosen for its own sake or some other further end. And here they're citing again Veritatis Splendor 78 on the moral act. As an aside, Tom, you know this well. Veritatis Splendor 78, incredibly important paragraph in moral theology, defining the moral act, defining the moral object, I should say, and so really this is pretty deep moral theology here that the bishops are inviting us to do. So I think it's a good moment for those of us who are ethicists to return to Veritatis Splendor 78 to really understand what this development is getting at. Now, it's a development of language, I would say. I don't
Hmm.
think there's any development in the ethics here. It's a clarification of language. It's a conceptual clarification. It's a bit technical, as I just noted, because 78 is a high-level moral paragraph in moral theology. Paragraph 78 of Veritatis Splendor, I should say. But you really do have to understand that paragraph in order to understand this developed language. But again, as I read it and as we discussed, and we've discussed this with a number of healthcare ethicists, there is no change of ethics here. So it's a clarification, but no operational or substantive change of practice.
Yeah, and I think that's important to note because, of course, abortion, it's like the number one culture wars issue that comes up, but really this really shouldn't result in any kind of change in practice. Of course, like I said with the previous one, the ultimate authority and conversation on that is the local ordinary. So I would say if people are, having questions about what does this language mean, does it involve any kind of change of practice? That's another good question to bring to that conversation with the local ordinary. But from our standpoint, it's a technical clarification of language, but not a development in terms of how abortive services are not offered in Catholic healthcare.
That's right. Yeah, it's
Yeah,
really good for people like us who studied Aquinas and
yeah,
have a reason to go to Veritatis Splendor, which is a phenomenal document. Go back to Aquinas on the moral object and the Prima
yeah,
Secundae, and really nerd out for a little bit on these important, but really, I mean, the moral object. Some commentators have said is the most difficult part of moral theology
yeah.
is being able to understand it and name it in an action. Um, but absolutely essential in abortion ethics, as we well know.
Yeah, I'm having a little flashback of graduate seminars, and let's look at Veritatis Splendor and dig in. But we love that stuff.
That's
Uh,
right. That's right.
yeah,
That's why we do it. Yeah.
yeah, yeah. Okay, so that was the second major update. The other one that we noted uh, is ERD number 60. So this will be the third major update. That is the brand new ERD, revised and updated to deal with this phenomenon of VSED, voluntary um, stopping of eating and drinking. And this is a practice that we've seen emerge, not necessarily, wide scale, but there are sort of anecdotal stories of this happening. I mean, we know what's happening in general, but specifically whether it's happening in Catholic healthcare, we don't necessarily know. But the bishops wanted to comment on this. It's a new form of ending one's life in states where physician assisted suicide is illegal by, just as it says, stopping eating and drinking. Um, so this directive really has five specific guidelines, which is that we inform patients. So if a patient were to express an intention or desire to practice this in one of our facilities, the directive says to inform the patient that we will not facilitate that process because it is a form of suicide, uh, and that it then asks the professionals involved to dissuade the patient while respecting their freedom from engaging in the practice. It does say that we continue to engage in pain management just like we would with anyone during end of life care, even if they are already practicing VSED before they come for treatment. Um, so in some sense, that gets pretty technical in terms of, when are we treating pain caused by the progression of a disease versus pain or discomfort that might be coming from the practice of VSED. Uh, but the directive does say that we can continue pain management. And then there's a recommendation of providing psychiatric care if that's warranted, as well as consulting the pastoral team if we're dealing with this in one of our facilities. Um, so again, it seems to me like the crux of this is a desire, and we're going back to the moral object again, right? Is that as healthcare professionals, we are avoiding formal material cooperation with any form of suicide or assisted suicide or euthanasia. And that seems to be, as I read it, the main intention behind this directive. Anything that you would add to that, Dan?
Yeah, no, I think it's a good point. I think it's, V said that's voluntarily stopping eating and drinking, as you noted. has come up within the physician-assisted suicide community as a workaround. So the primary proponents of this are the primary proponents of physician-assisted suicide, like Timothy Quill, Dr. Timothy Quill. If anyone's read his work, he's one of the best, known advocates of physician-assisted suicide. And so, yeah, it is. Just as you said, I mean, more than half of the nation in terms of population does not have access to physician-assisted suicide. That could be changing. I mean, the state of New York, there's a lot that's going on as we record this that is changing the laws in certain places. But for now, VSED is an option that many people. I shouldn't say many people because it's not widely used. It's rarely used. It's difficult to do. If you research VSED, it's very difficult to do. It has a lot of moral problems baked into it, other than the fact that the patient's intending to commit suicide, which from the Catholic perspective is the central one. But how do we care for people even when they do things that we disagree with?
Mhm.
And I think this directive does a phenomenal job of providing guidance. It does have those 5 specific guidelines, which I think are important. And yeah, it tries to ensure that we care for patients while not cooperating immorally in their suicide. But it really puts Catholic healthcare in a horrible position. And so, again, I think this really leads into the next one.
Yeah, I was
He
just
said
thinking that.
leads into the next one because the final one that we're looking at is, for the first time, the ERDs include the word palliative care in them. So palliative care is directly addressed in 61. That's the one that you could say. It's also mentioned directly addressed in 63, but 61 is the central one, where palliative care is really at the center. And the idea here is that we have options.
Mhm.
It's not as if the only thing we can do is either provide all the supportive care that a patient could possibly use, or do nothing, right? We have palliative care that is not just used at the end of life. It can be used for uh, any treatment protocol that the patients undergo. But specifically, it's one of its most important applications is for patients at the end of life, to provide that whole person care, to relieve pain, but also to allow them to be accompanied both personally, relationally, spiritually. Here we see Samaritanus Bonus again playing a really important role in the revision of the ERDs, so that patients don't feel like the only option they have is either to do everything, or that they feel like their life is meaningless, and so VSED becomes the preferred option. Palliative care is this kind of wraparound care. And I think what's interesting is that here the bishops have really put a stake in the ground, because there has been a movement afoot for the past 15 or so years, maybe even a little longer, saying that palliative care is really kind of this stealth euthanasia. It can be a nefarious practice. And while we could admit that any medical practice can be used poorly, done poorly, used for the wrong ends, right? We could go up and down the line of, right, that's obvious. Palliative care in and of itself, when it is practiced as it is indicated, if it's practiced in the way that it's designed, is not stealth euthanasia, but rather really deeply reflects the Catholic perspective on dying, and how to deal with pain and suffering. Because it does provide this kind of whole person care. And I would invite folks to read, if you want to read more about this, the response to the critique that palliative care is stealth euthanasia, go back to an article that Ron Hamill wrote in 2014, where he outlines the arguments against palliative care and answers them. And we'll link that article in the show notes. It's an article from Health Progress. But I think it's a really important uh, development and new directive for the ERDs, and it really does raise up palliative care in an important way.
Yeah, and I think you're absolutely right that it's linked to the previous conversation about VSED. It's linked to the broader discussions, in our culture right now about physician-assisted suicide. So that this is really, I mean, I personally, and I know you agree with this, Dan, we've talked about it, and I've talked with others, like, I feel like this is one of the things that the Catholic tradition, and Catholic healthcare in particular, has to contribute to that dialogue about, how do we really care for a person at the end of their life as they go through the natural process of dying? How do we accompany them? How do we tend to their suffering in a way that is humane? How do we make sure they are insured by loved ones, or insured, surrounded by loved ones, that they have access to pastoral and spiritual care, regardless of their faith tradition or none? Like that's really what we're talking about, is that holistic approach. Um, and you mentioned earlier, and it reminded me of conversations that I've had with providers, particularly a couple times in end of life ethics consults where palliative care physicians and professionals were brought into the discussion. You mentioned like that distinction between palliative care and hospice care. And I think there's a lot of confusion. In fact, I admit myself, I didn't understand the difference until I was actually in, ethics discussion or consult around some of this. Um, and so I think it's just worth clarifying that, palliative medicine and care in general can be used for a lot of different chronic conditions. And just because palliative is mentioned by a professional doesn't mean hospice. It doesn't mean we're moving towards the process of dying. So hospice is a specific form of palliative care that is offered at the end of life in the final stages of disease progression, and dying. And I'll put a link in the show notes as well to the National Institute of Health discussion of the what palliative care is and those distinctions. But palliative care can include things like heart failure, chronic obstructive pulmonary disease, cancer, dementia, Parkinson's, other things like that that are not immediately causing death, right? So it's about symptom and pain management over a long term. So I just think that's important to keep in mind. And I think this is one area where I would love to see more development being done, both, in terms of research, but also in terms of practice. How can Catholic healthcare really hold this up as a very effective and humane and compassionate way of dealing with folks and caring for them at the end of life? So, a really important development.
Yeah. Yeah. It reminds me of the Ars Moriendi tradition of the,
Mm.
16th century and onward. Theologians thought a lot about how to die well. What does it mean to die well? And I think we've moved away from that notion that there can be such thing as a good death, or the dying process can go well. I mean, as well as it can, right? It's an awful, horrific, terrible thing in many ways, but there's a lot of beauty um, that can be realized. But today, we follow the Woody Allen approach to dying, which is I'm not afraid of death. I just don't want to be there when it happens. And palliative care is about allowing people to die as well as they can, to be surrounded by family and friends, embraced by the religious community, to have an opportunity to become right with God and others. Right? It gives that opportunity. It creates space for those things in the medical setting, and I think it really deeply reflects what we believe about life and death and dying, and I think yeah, I think your call to reflect more on this, I think, is an important one. Well, Tom, is there a final kind of reflection that you want to leave us with before we end?
Yeah, that's a great question, Dan, as we kind of wrap up here. You know, I'm kind of thinking like stepping back for a second and taking the big picture again of what are these ethical and religious directives, right? These are directives which gives us a clue that they're practical, right? They're intended to guide people who are practicing medicine, whether they are healthcare professionals, providing the direct care, or they're mission leaders, ethicists, administrators supporting that work. This is guiding the practice of medicine within Catholic facilities. Um, so, there are elements that we heard about from Nate and that you and I talked about where there are new developments, say in doctrine or in ethical reflection in the Catholic tradition that we're seeing sort of integrated. Those are spurred by responding to new situations that are arising, right? The medical practices around care of transgender persons, VSED, care at end of life. These are areas where medicine is developing and new practices are developing. So that's why these ERDs keep getting revised and updated because the practice of medicine, I mean, I don't have to tell our listeners is, I mean, the changes in practice and technology are just so fast you can barely keep up. So I think that's just helpful to keep that kind of big picture in mind that this is a both a pastoral and a doctrinal response to some of those issues that are coming up. But it isn't primarily meant to be like a doctrinal document, right? Like it's reflecting the outcome of those processes that are happening elsewhere in other areas where theology is practiced. Um, but it is, and it's mirroring those. So I'm not saying it's not accurate, just that it is putting those into a practice for how professionals can apply them. And I'm thinking about there's a quote that I love from theologian and historian Yaroslav Pelikan. I love saying his name. Uh, and he said that after every ecumenical council, it took 100 years for the church to live fully into whatever new doctrine or development was coming out of that council. Now, this is not an ecumenical council. The last one was Vatican II. So it's, maybe not 100 years. But I think the point is that we've outlined things in here that we're going to continue reflecting on and practitioners are going to reflect upon. And that will continue to develop. And in fact, I'm sure we will continue to reflect on that in the podcast and in the work that we do in the center. So the last thing I'll say, I think, is again just that we've seen that emphasis on the relational and the pastoral and care for persons. So we saw that renewed emphasis or language on women and particular vulnerabilities that they're dealing with, persons struggling with and experiencing gender dysphoria, challenges at end of life, that we're continuing to see that practical, pastoral, and compassionate response being integrated. So I think that's kind of where I would leave my big picture reflection. What about you in terms of takeaways?
Yeah, no, I think, nothing was terribly surprising here. I think many of us who are watching these things expected the document to look like this in many ways. But we still have questions. I mean, no document is self-interpreting. So in order to understand what's been the authoritative guidance that's been provided, we have to interpret it. And that's going to require conversation, dialogue, whether it's, as you noted earlier, with your local bishop, among ethicists, mission leaders, physicians, nurses, right? So it has to be understood. So there's some work of interpretation that needs to happen. And then there's application. So it's authoritative guidance. And then, but it's not on specific cases. It's providing general guidance that then has to be brought to individual patients or questions in organizational ethics or whatever it is. And so we've got to interpret and apply it. And I think those conversations are just beginning. As the document gets promulgated, those conversations now can begin. We hope this podcast and other work that we do as a center will help that process of interpretation along, and we look forward to continuing that conversation to really understand what's being said and how it ought to be applied in Catholic healthcare today.
Yeah, that's really well said. And I think, we're coming to the end of a recording of a podcast, but I think this should be taken as an initial reflection and commentary,
Exactly.
and not as a final word about any of these issues, because these are very much living issues within patients' lives and their families and within the life of the church. So, yeah, we hope that this has been helpful for those out there, and stay tuned for more thoughts from us and other guests that we invite into this dialogue. So, on behalf of Dan Daly, I am Tom Bushlack, and this has been Ethics on Call. And as always, you can find our podcast on YouTube, Spotify, Apple, as well as our website, which is theologyandethics.org/podcast. Again, that's theologyandethics.org/podcast. And as always, if you're on one of those podcast platforms, we ask that you follow us or subscribe to our page. Leave us a review, preferably 5 stars, but we leave that to your discretion. And feedback and comments on those sites are very helpful for helping people to find the podcast. And as always, we'd love to hear from you. If you want to drop us a note on the contact tab on our website, we'd love to hear your questions or comments or feedback. Thanks for being here with us, and we look forward to being with you next time. Take care.